evening, all of you, all the medical fraternity who have joined at the weekend right now. I can understand about it. But I think this is a very important topic which we have been brought up through the virtual meetings. I think you all know virtual is easy platform where we can gather the information. So before starting today's webinar, I just want to give a warm welcome on behalf of Lloyd Healthcare to all the medical fraternity who have joined today. And Lloyd Healthcare is always been committed in terms of bringing the science all together to all of you. It's not only about the expert insights, but we are bringing the conference highlights, even evidence-based updates from the top journals like Jack. Even we are bringing a lot of insights from the NAGM also to all of you guys. And that's really important. We are bringing from the experts like we have been sitting here right now. And the initiative what Lloyd Healthcare has been taken, that initiative name is nothing but Syncore. It will be a monthly webinars we have been taking up for a long period of time to bring a lot of updates which are coming, different top journals, even conferences which are happening through the experts. I think this is a platform where which can bring that kind of insights to all of you. Even you can ask the questions at the end of the session, where you can just put the comment in the comment. You can put your questions. That questions we're going to take up, and we will ask that particular question to the experts. So absolutely great. I think a lot of SCPs has been today joined, and we are starting on time right now. So before starting it, I think you all know ADA has just been concluded, and there are a lot of incidences has been happened. There are a lot of insights has been come. Most importantly, if I talk about obesity as in therapy area, GLP-1 analogs, a lot of things has been discussed, and even hot trials has been discussed. But more importantly, the AI part is also been discussed too much. I think we have been on the verge right now using AI a lot in diagnosis also, even in terms of cardio diabetes therapy. So today, I think we have an eminent speaker. Let me take this opportunity to first of all introduce our top first eminent speaker. I think most of the SCPs knows about them. Every conference, whenever there is endocrinology, diabetes, whatever it is, the first name. I think if I talk from an angle perspectives, even from experience perspective, it comes Dr. Supratik Bhattacharyya. And I think most of SCPs knows about the way he delivers the topic, whichever he got, and he gives a lot of justice to that. So in brief, if I talk about him, he is a director at SKN Diabetes Endocrine Center at Calcutta. He is a senior consultant endocrinologist, and more importantly, he is having more than 40 publications, 7 book chapters, and most importantly, he is a founder, president, and secretary general at AMOC. More importantly, you know, American Association of College Endocrinology. I rate it as the second topmost organization where he is being associate editor, clinical diabetology. I think that is something. Second, most importantly, if I talk about Sir, is top 2 reviewer globally for endocrine practice at ACE. I think multiple awards. It will not going to stop it. He got around ACE Best Research Travel Grant, RSSDI Travel Grant, American College of Physician Excellence Award, and most of the things. And that's what he is having that particular capability per se, if I talk about it. And I think the topic what he has been got is innovation, from innovation to implementation, and the more importantly, AI technology and certain ADA updates. And I think you all know he is being the part of that particular conference. He has went up there. He has attended entirely thorough conference. And the time is short. Probability he will bring the important things from the ADA and he will give and he will add the practice to all the SAPs. I think, sir, without wasting much time, I will just hand over to you, sir.
Thank you, Mr. Basant. It's been a very kind introduction for you and from your side, and it's a pleasure being on board. And a welcome to all of you. Am I heard properly?
Yes, sir, we can hear you.
Okay, so a warm welcome. Just a disclaimer that I'm not a very techie person. I'm trying to get on board with AI. I'm obviously, my expertise lies in, obviously obesity care and endocrine management. But nevertheless, I tried to do justice about the topic that had been given for today. So I'll be talking about ADA 2026 technology and AI. So whenever we hear terms like AI, machine learning, digital therapeutics, foundation models, or automated insulin delivery devices, many of us feel that these concepts belong to the engineers rather than clinicians. However, ADA 2026 clearly demonstrated that these technologies are rapidly moving into routine clinical practice. And I try to simplify the development and focus on the practical questions like how can these innovations help us improve outcomes for our patients with diabetes? The purpose of this presentation is not to make everyone a technology expert, obviously, but rather to make you understand what is clinically relevant and what may soon become part of the routine diabetes care. Next slide, please. So this presentation would be divided into two sections. In the first section, we'll discuss emerging technologies, including artificial intelligence, continuous glucose monitoring, automated insulin delivery devices, digital therapeutics, and connected care. In the second section, we'll review some of the most important studies presented at ADA 2026 and also discuss their implications on the everyday clinical practice. Now, by the end of this session, I hope everyone will have a practical understanding of where diabetes care is heading over the next decade. Next slide, please, where we talk about the new technologies transforming diabetes care. So traditionally, we know that diabetes management has been more reactive. So a patient develops hyperglycemia, and then we gradually, get them onboarded with some kind of OHA, and then gradually intensify the therapy with OHAs or injectables. Now, if a person develops hypoglycemia, obviously we down titrate the dose. And if a complication develops, we intervene. So there's an emerging paradigm in spectrum of predictive medicine. So we want to act before that incidence has happened. So we don't want a hypoglycemia to happen. So we want to predict that prior to a hypoglycemia episode or complications from developing. So instead of waiting for these events to occur, technology aims to identify risk earlier and enable preventive action. So this is very similar to how cardiology evolved, and we no longer wait for myocardial infarction, for example, and we start taking the preventive measures. And we should be doing the same with diabetes as well. Now, next slide, please. Now, one of the most exciting areas of AI is hypoglycemia prediction. So many of our patients using insulin experience episodes, they experience low glucose, often unexpectedly. And current CGM systems provide alerts when glucose is already falling. So if you've used a sensor, for example, you'd see that there's a trend, so which shows that whether over the next, say, couple of hours, the sugar is going to go up, down, or it's going to remain the same. So AI, in fact, attempts to go a step further. It analyzes thousands of previous glucose patterns, insulin doses, meal behaviors, and activity levels, and it can estimate whether a patient is likely to develop hypoglycemia in the near future. So a useful analogy is like weather forecasting. So you can forecast, like the meteorologists cannot predict every rain shower perfectly, but they can provide sufficient accurate forecasts. Similarly, AI is helping forecast glucose trends before dangerous events happen because they're pulling out data from different sources and then helping us predict what may happen in future. And this obviously reduces severe hypoglycemia and improves patient confidence. Next slide, please. And here would be talking about hypoglycemia forecasting, an unresolved challenge. So despite all technological advances, severe hypoglycemia remains a major clinical problem. ADA data shows that approximately 1 in 5 patients with type 1 diabetes using advanced technologies still experience severe hypoglycemia. Now, why does this happen? This happens because predicting glucose accurately becomes increasingly difficult as we look farther into the future. Now, current systems perform reasonably well for the next 30 to 45 minutes. However, accuracy declines significantly beyond 1 hour. So human behavior is difficult to predict. Meals, exercises, stress, and illnesses all influence the glucose patterns, and therefore hypoglycemia forecasting remains one of the most important unmet needs in diabetes technology. Next slide, please. Now we are going to talk about the evolution of prediction models. Prediction models have evolved considerably, as we know. The earliest models relied only on glucose values, but these systems were simple but limited. The next generation incorporated additional information such as insulin doses, meal intake and physical activity. And these models improve prediction, but still struggle to generalize across different populations. The newest generation uses AI foundation models trained on millions of glucose readings collected from thousands of individuals. Now, useful analogy is medical education. So a clinician who has seen 10 patients would develop certain kind of experience. And that's why we say that you need to be experienced and you use that clinical experience to predict an outcome. So a clinician who has seen thousands of patients would develop expertise. Similarly, AI becomes increasingly effective as they learn from larger data sets. Next slide, please. So we're talking about novel sensing modalities now, and an important question is whether glucose alone provides sufficient information, and the answer appears to be no. So during hypoglycemia, multiple physiological changes occur, like, for example, if your autonomic system comes in, your heart rate changes, you start sweating, autonomic nervous system, as I said, would have been activated, the breath compounds may change. Now, researchers, therefore, exploring wearable sensors that measure these signals, and future systems will combine glucose, heart rate, skin conductance, breath biomarkers to create a more comprehensive assessment of hypoglycemia risk. And this is called a multi-sensor fusion. Now, I want to give a key clinical message. For example, the practical takeaway is very simple. The future of hypoglycemia prediction will likely resemble cardiovascular risk prediction. So today we use multiple variables such as age, blood pressure, cholesterol, and smoking status to estimate the ACVD risk. Similarly, future diabetes systems will generate a composite hypoglycemia risk score using multiple biological signals. And this approach is likely to be more accurate than relying on the glucose data. Now, let's come to the concept of the Gluforma foundation model. Now, Gluforma is one of the largest AI glucose prediction models that was presented at ADA 2026. It was trained using over 10 million glucose measurements from more than 10,000 individuals. The significance is not the specific software. The significance is the concept per se. So medicine is entering an era where AI models can learn from enormous data sets and generate individualized predictions. So we are in an era of precision medicine. So just as large language models transform communication, foundation models may transform glucose forecasting and diabetes management. Now we'll be talking about, next slide, please. So we'll now talk about Twist automated insulin delivery device. Now, we'll be moving on to the prediction, from prediction to treatment per se. So many patients struggle with insulin titration. They must estimate carbohydrate intake, determine correct doses, and adjust therapy throughout the day. So we know we teach type 1, those who are living with type 1 diabetes, how to do the carb counting because it's very important for them. But we know that the newer devices like the 780G pump, for example, they have automated, they're automated and they can predict, but nevertheless, they gradually train based on the individual pattern. So automated insulin delivery systems attempt to reduce the burden. The Twist system combines CGM data with an insulin pump and an algorithm that is continuously adjusting the insulin delivery. The useful analogy here would be an autopilot in aviation. So the pilot remains responsible, but the system assists with many routine tasks. Similarly, automated insulin delivery supports, but does not replace the patient involvement. So you know that, whenever something goes wrong, obviously you have to fall back on the usual basal bolus, which has to be given humanly, because there are certain challenges when it comes to pumps. There can be blocks, and you have to be prepared, and the patient has to intervene himself or herself to take charge. So moving on, the next is about the results of the Twist trial. The trial demonstrated substantial improvements in the glycemic outcomes. Time in range increased from approximately 60 to 77%. This means patients spent significantly more time each day within the target glucose levels. Importantly, this involvement occurred without an increase in hypoglycemia. And obviously, a clinical perspective, this results suggest that automation may improve both efficacy and safety. This is particularly relevant for patients who struggle with complex insulin regimes. So life has become much more simple. And whenever you're doing something humanly, the chances of error is significantly higher. So with the automation in place, with this kind of assistance in place, the chances of error comes down and the quality of life significantly improves. And the patient, obviously feels that in their day-to-day life. Now, moving on, we're talking about the continuous glucose monitoring now. And continuous glucose monitoring is rapidly becoming the cornerstone for modern diabetes care. Historically, diabetes management relied heavily on A1C. So we are coming off from the long-term, variability markers like A1C, because we know that 2 or 3 people can come with the same A1C, but yet have a very different time in range. So we need to understand that. And while A1C is still important, so we ask for A1C whenever they come every 3 months or so, we want to understand their trends and patterns, and this comes from the CGM information. So it provides you a dynamic information and the changes that happen on a day-to-day basis. So you can precisely, get on board with a customized, intervention for that particular individual rather than having to wait for 3 months. So it tells us where the glucose is now and where it is going to head and how rapidly it is changing throughout the day and in between the days as well. So this additional information enables more informed clinical decisions and more personalized patient education. Now, next slide, please. And we'll now talk about the STRIVE trial and Omnipod 6. So the STRIVE trial evaluated the next generation Omnipod 6 system. Compared with the previous generation, Omnipod 6 achieved superior glycemic outcomes. Patients spent approximately 1 additional hour per day within the tight target range. And importantly, there was no episodes of severe hypoglycemia or diabetic ketoacidosis. The significance is that technology is becoming increasingly sophisticated while maintaining safety. So for clinicians, this provides reassurance that tighter glucose targets can potentially be achieved without increasing the risk. So if you remember, go back to the UKPDS days, we were concerned with the tight glycemic control, like say, for example, the VADT, the chances of hypoglycemia increased as you increase the tighter control. But with this kind of monitoring and vigilance, obviously the chances of achieving tighter control without causing any risk of hypoglycemia is significantly higher. Next slide, please. Here we talk about FiberMore AI behavioral intervention. And one of the most interesting studies at ADA 2026 involved lifestyle intervention rather than medication. And participants interacted with the AI-powered chatbot that provided dietary coaching. And the system encouraged high fiber intake, goal setting, and behavioral modification. The intervention resulted in substantial increases in dietary fiber consumption and modest A1C improvements. Now, the broader message is that AI may not only assist clinicians, but also help patients maintain healthy behavior between the clinic visits. Next slide, please. So we are now moving on to connected care and digital therapeutics. So connected care refers to linking patients, clinicians, and devices through digital platforms. So when the patient is away from your clinic, they still are connected to you. You can still have visibility of how they're doing. So examples are remote CGM monitoring, telemedicine consultations, and smartphone applications. So this significantly improves your confidence as well, because you are constantly monitoring the patient, and the reliance of the patient on the doctor also goes up, because they know that if there is any challenge, they can fall back and seek help whenever needed. And it seems like somebody is watching over them all the time. So this approach is particularly relevant in countries such as India, where specialist access remains limited. So if they're going from the cities away to their home town, which is maybe a few hours away, it might not be possible for them to come back every so often. So yet they're connected on a digital platform, like say, for example, they can fall back on teleconsultations. They might be connected over a connected CGM device where the doctor has visibility. So a single clinician may be able to supervise many more patients through digital monitoring than through traditional clinic visits alone. So connected care may improve efficiency and expand access. And we know that one of those such platforms has been enabled in India as well, and is being well taken by many people are getting onboarded with that platform. So barriers and enablers in India. Now, India faces several barriers. Cost remains the biggest challenge. Awareness among both patients and healthcare professionals are variable. Infrastructure limitations persist in some regions. India also possesses major disadvantages as well. Like say, for example, everybody has got access to smartphone. Digital health initiatives are expanding rapidly. Patients increasingly comfortable with using mobile applications, and therefore, despite challenges, India may become one of the largest adopters of digital diabetes care. Now, moving on, next slide, please. We're talking about the future of precision diabetes management. So looking ahead, four major developments appear likely. First one is individualized risk scoring. So one shoe wouldn't fit all, and we personalize the care based on the individualized risk scoring. Second is multimodal sensing. Third is adaptive insulin delivery system that learn from the individual responses. And the fourth one is population scale AI models that support clinician decision making. So the common theme is personalization. The future is unlikely to involve one shoe fit all. And we would definitely want to get on board with this kind of precision technology and precision care for our patients. Next slide, please. So transition to ADA 2026 landmark studies. Having reviewed technological advances, let's now examine some of the most important therapeutic studies presented at ADA. And these studies may directly influence treatment decisions over the coming years. So key practice changing studies. Next slide, please. One of them is retatrutide. I think it's going to be the era of GLP-1 backbone, and many other things will be added onto it. So, for example, retatrutide would be a triple agonist, as you know, and would be hearing more about this from our upcoming sessions. But just to emphasize, we already have tirzepatide, which is basically a native GIP with a GLP-1 analog, additionally, and we obviously, achieve greater weight loss as compared to GLP-1 receptor analog itself. So similarly, if you have triple agonists in place, like say, for example, if you have a GLP-1 with the GIP, along with that, if you have glucagon, for example, the chances of weight loss, achieving higher weight loss is going to be even more significant, and that's what retatrutide does. Orforglipron, again, is a small small peptide, and it's a non-peptide. And the advantage of orforglipron is that it doesn't require any meal timing, so it can be given any time of the day, whether prior to meal or after meal, doesn't matter. Unlike oral semaglutide, which needs to be timed, that it has to be taken with 120 mils of water, and it has to be taken at least half an hour to 1 hour ahead of the meal in empty stomach. These kind of challenges will not be there with orforglipron. And once we have maxed out, so if we reach the maximum tolerated dose of, say, for example, tirzepatide or once weekly injectable semaglutide, and when you want a maintenance therapy, you can fall back on things like orforglipron, because many of the patients would have a challenge continuing with injectables, and this would give them a chance to get onboarded with a simpler oral alternative. Cagrilintide, again, is a dual agonist. and it's going to highlight the value of dual mechanism therapy. Large real-world studies reaffirm the cardiorenal benefits of SGLT2 inhibitors. The future talks are all going to be about the GLP-1 receptor agonists, or with the backbone of GLP-1, many other co-agonism as well. Along with that, we'd always have a place for the SGLT2 inhibitors as well. So Indian real-world evidence supports the effectiveness of practical combination therapies. Together, these studies suggest that diabetes management is increasingly moving towards and more effective and more individualized interventions. And 5 shifts redefining diabetes care. So if I want to summarize the ADA 2026 into 5 points, one would be the CGM is expanding beyond insulin users. So we are routinely getting on board with CGM in those who are pre-diabetic individuals, those who are type 2 diabetes, GTM patients, or just for understanding the pattern. Second one is automated insulin delivery, which is becoming mainstream. Third one, time in range is increasingly becoming important rather than long-term variability factors like HbA1c. Artificial intelligence is entering clinical practice. Digital tools are supporting both patients and clinicians, and these trends collectively represent a major evolution in diabetes care. What about the implications for India? India carries one of the largest burdens of diabetes worldwide. Therefore, even modest improvements in care delivery can have enormous public health implications. Technologies that improve monitoring, automate routine tasks, and expand access may help address workforce and shortages and improve the outcomes. And the challenge will be adapting these innovations to local realities. Next slide, please. And we're talking about translating evidence into practice, and this is the most important part. Implementation should occur gradually. We don't expect everyone to get on board with technology and translate this into their practice right away. But we should educate ourselves and our patients, like I'm trying to get on board with AI and the newer digital platforms. I think everybody should get on board with these newer technologies and offer this to their patients. We should adapt in international evidences to Indian populations. We have to obviously modify that in Indian perspective. So that's why we require our own consensus, because we know that Indians are very different phenotype, and we need a very different kind of individualized or customized consensus for our individual for our patients. So we should focus initially on the high risk patients who stand to benefit the most. And finally, we should continuously evaluate local outcomes and generate India real world evidence. And we should audit that data and then translate that into clinical practice. So final key takeaways. 3 messages summarize today's discussion. First, diabetes care is becoming predictive rather than reactive. So we don't wait for an event to happen or complications to occur. We generally get on board because of the newer technologies. So we can predict what is going to happen and start intervening. Second, CGM and time in range are becoming central clinical tools. Third, artificial intelligence is not replacing physicians. It's just that physicians need to get on board with artificial intelligence and use it for enhancing their care for their patients. So instead, additional information is going to help make them a better clinician. So with that, thank you. In closing, I just want to say that technology alone does not improve outcomes. Outcomes improve when technology is combined with clinical judgment, and this is irrepressible. And obviously, the empathy that comes from the human interaction is obviously going to have a sort of a very strong implication when it comes to patient care. Patient engagement and compassion. This is very, very important when it comes to care. And obviously, the machines can't do that. You need a human intervention in this regard. So artificial intelligence would not replace doctors. Please don't be scared about that. So whoever understands and appropriately uses technology would be better positions to deliver a personalized, proactive care for their patients, and they would become better clinicians overall. So with this, thank you so much. And if there are any questions, I'll be happy to take them for you.
Sir, actually, a lot of questions has been there. As I said, there are two questions I have been selected right now on the topic what we have been spoken of. So the first important, I think you talked about CGM, and there is Dr. Anup Mishra from Lucknow. He has been spoken about it. Sir, we have been hearing about CGM for years now, but most of our type 2 diabetes patients are on oral medications, but they are not using the CGM. Maybe the cost factor or maybe the awareness, how to address this challenge, as the CGM plays a very vital important role when a patient is uncontrolled diabetes, having complications a lot. I think how to address this, that's what Dr. Anup Mishra is talking about it.
So I think the most important thing is advocacy. You have to have a conversation with the patient and tell them why this is important. And whenever there's a disparity between, say, the HbA1c and the daily readings that they're getting, the SMBGs, you need to understand why there is a difference, and this can only come out if you are getting onboarded with the CGM, for example. So that's why I said, 3 or more people may have very similar HbA1c, but if you look at the individual trends, it's going to be very, very different. So one person might be having more than 90% time in range, where other person might be having lots of highs and lows. So to understand that, you have to talk to the patient regarding the importance of this CGM. And now we have, guidelines which are advocating the use of CGM in type 2 diabetes. And so it's very easier. I think it's much more easier to convince the patients regarding this. I, for example, advocate this for most of my patients because they get to understand the eating pattern, their daily trends, and usually they can empower themselves regarding the dietary modifications that are there or the lifestyle modifications. And it's easier for me to intervene in terms of precision care if I want to, up titrate or down titrate any of the medications.
Thank you so much for a wonderful answer to the questions of what you're saying. CGM has always been a challenge. I think counseling was the best part. I think you have been mentioned, sir. I think that's what SAP has been doing it. Coming back to the AI, sir, there is one question from Dr. Sunil M. Jain. It is from Jaslok Hospital. I think you know about him, sir. He is talking about AI use in prediction of hypoglycemia. And it is quite been difficult in Indian scenario because most of the Indian diet is something different all about it. Daily pattern is also, I think he said, altogether different. There is no fixed timing in terms of eating the food and taking the medications. So should it will be reliable for getting the AI in prediction of hypoglycemic events?
Absolutely. I mean, so, as we said, your CGM gives you trends, and more data you feed into the AI, better will be the learning. So if we get a lot of data coming in from India, as we said, like if more and more doctors get on board with CGMs on a regular basis and this data is fed to the AI, they would learn better regarding the risk predictions and the patterns. So I think it's all about the learning. More importantly, we now have certain things. Let's say, for example, the ultra rapid acting insulin, the prandial insulins, they work very, very fast, and they can be given post meal as well. So a person would see how much of carb they would have taken, for example, and then decide on the prandial dose. So these are very different from the earlier, the human counterparts, where typically the bolus dose was given like at least 20 or 30 minutes ahead of the meal. So for any reason, if they couldn't eat, or the amount of carbs in the plate was low, they would go into hypoglycemia. So I think we are improving on the molecules per se, and also on the technology. So we should get on board with that so as to minimize the risk of hypoglycemia.
I think that's a nicely answered, sir. One last question I will want to talk about it. Any special comment on SEMA use in Indian patients, sir? Any special comment from your side?
Yeah, so I think we had been using GLP-1. Say for me, I'd been using GLP-1 for the last 10 years or so. So we moved on from the first generation liraglutide, which was a short-acting once daily. to say dulaglutide, which was once weekly, and then we had the oral sema tablets, and then we moved on to the originator once weekly injection semaglutide, and then also the tirzepatide as well. And recently, injectable semaglutide has been off patented. So the price reduction uh, has been a blessing because now more people can get onboarded with once weekly semaglutide. The only concern is, there are two perspectives. One is the glycemia control, and the higher doses of once weekly injectable semaglutide, 1.7 and 2.4, are for obesity management. So, handful of pharmacological companies have launched the 1.7 and 2.4. Majority would have launched it up to 1 mg of once weekly semaglutide. So, and also, the approval that they have gotten is in the space of diabetes management and obesity management. But we know that these GLP-1 receptor analogs like once weekly semaglutide has the originator has acquired a lot of data in terms of organ protection. So, like say for example, those with a background of ASCVD, CKD, for example, we have the flow trial. We have the sustain 6, and we have the select trial in the obese individuals, flow trial for the CKD. We have the stride trial for peripheral vascular disease. So we are using semaglutide not only for diabetes management but for organ protection. Now the challenge for us is that many of our patients would already have a background of these. So they would already have an event in the past, or they would be at a high risk. So we are compelled to use originator at many times. But when it comes to using it in the space of diabetes, we also know it's a very robust anti-diabetic agent, and also in terms of obesity management as well. So that's where the Indian synthetic semaglutide once weekly stands at the moment.
Great, sir. Thank you so much. I think nicely answered. I have just taken three. There are a lot of questions are there. But sir is leaving right now to all the SAPs who are logged in. A wonderful, insightful session from the ADA. Probability, the hot topics, and the certain important discussion which has been happened in ADA. He has been brought up here and he has shared with all SAPs. Thank you so much, sir, on behalf of Lloyd Healthcare for getting out that particular time. I know, so you are going into the conference. You have a session right now. But I think bringing out such a time and giving that wonderful time to all the SAPs who are watching to you as usual. Thank you so much, sir.
Thank you so much.
You
Thanks. It's
can
wonderful. Thank you.
go
Thank you so
forward.
much.
So thank you so much.